Hello, and welcome to the Industry Innovators podcast. I'm your host, Sarah Cornett. I'm the founder and CEO of SE Innovate, an AI consulting firm helping clients with every step of their AI journey. AI is making a huge impact throughout the pharmacy industry today. From personalized medication recommendations to medication safety to drug development and discovery, the opportunities to utilize AI solutions across pharmacies is staggering. Joining me today is my dear friend, Dave Wolfe. Dave has over 30 years of diverse experience in pharmacies, from precision medicine to pharmacogenetics to business development and to healthcare consulting. Dave has a proven track record in strategic implementation of clinical decision support software and expertise in pharmacy and healthcare IT consulting. Dave has experienced significant technological advancements within the pharmacy industry, and I'm very excited to dive deeper into his experience and his predictions for the use of AI solutions in the pharmacy industry. Please join me in welcoming Dave Wolfe to the Industry Innovators podcast. Welcome, Dave, to the Industry Innovators podcast. Thank you for joining me.
Well, I really appreciate the opportunity. Thank you, Sarah.
Well, I'm so excited to have you on. You've got incredible experience in the pharmacy industry. I was very excited to get to talk to you today and get your thoughts about AI and really discuss your innovation experience. So you've got over 30 years of experience in across
Don't
precision
say that out loud,
medicine.
okay?
Well, it's incredible. I mean, across precision medicine, pharmacogenetics, business development, pharmacy and healthcare consulting. So you've got just an incredible amount of experience across pharmacies and healthcare, and in particular on the technical side. So I'm really excited to hear, how you've experienced innovation throughout your own experience.
Oh, fantastic. Thank you, Sarah. And I joke about this. I don't like to think about the 3 decades, but it's been wonderful. It's been and probably one of the most diverse paths for a pharmacist to take, but and I'll tell pharmacists out there you can create your own path. And it's worked for me. And one of the, as we talk about technology and the implementation of that, my foray into it was kind of out of default. It was a reorganization. I was running a large specialty pharmacy program, and this is 2 decades ago. So this kind of puts it in context and timelines. It's like 2001, and a colleague said, "Dave, we're starting this. There's a new hospital opening, and we want you to build the pharmacy system." And I chuckled and
Wow.
said, I'm not a programmer. I haven't built systems." And they said, "Oh, you could figure it out." And it turned into probably the last 20 years, the bulk of it doing a lot of work with pharmacy information system, evolving into electronic health records and physician order entry. And that journey kind of really dovetails into what we're experiencing with AI, and I'm really excited about it.
Oh, that's so exciting. I can't wait to hear about all your experience with those like innovations. Could you talk more about the technology and how you've kind of
Yeah.
seen that grow from early on in your career to where we are today? I'd love to hear more about that.
Literally, we started when I started pharmacy, we were using typewriters to actually make labels for prescriptions. And I remember graduating from high school and getting a electronic or electric typewriter, and I thought I was the Mac Daddy. So fast forward to the early 2000s, and the big push there was literally we'd have paper charts, and that's how we tracked patients. I mean, there would be, and when I say paper charts, you could have a chart, literally a folder or a binder of patient health information, medical information that we as clinicians would refer back to. So you get checked into the hospital, and the paper chart would follow you. You go into surgery, the chart is on your gurney as they take you into surgery. So the big movement was to move from paper to computers. And that's the advent of the electronic health record. Now, the electronic health record was in place actually probably 35 years ago with the VA systems. And, it was really, under the engine under the hood, not many people heard about it because any hospital you went into was still all on paper.
Mm.
So as you look at early 2000s, there was actually federal legislation to computerize our health system. And the term came out CPOE, and computerized physician order entry, computerized provider order entry is what this evolved into. So the question is, how do you take all this information that's in these paper charts and convert it to a computer system? The easiest thing to do is just mimic what you have already. But the the benefit of transitioning like that is to take the opportunity to optimize. Let's layer in what is the best practice? What's the clinical evidence? Let's build order sets that physicians use based on this clinical evidence of the right way to treat a patient with a certain diagnosis. So you kind of have guidelines that you follow as you treat a patient. So that was what we ended up building with computer order entry. So I did a lot of work on the pharmacy side where I build prescription orders that made sense to these physicians and then embed them in these order sets. So you think of it, here's the roadmap or here's the recipe for treating this patient through this order set. And it's continually updated as new evidence comes out. And every hospital may do things a little bit different. So I implemented at least 20 different EHR programs, electronic health record. I'm using an acronym,
Mhm.
electronic health records, and probably 16 to 22 different systems across the country over that period of time. And everyone did it a little bit different, even though it's the same electronic health, same vendor. The big vendors at the time were Cerner. At that time, it was Siemens, and now you've heard of Epic and Meditech and Cerner are the three big ones right now in the health system space. But just watching people going from paper and the challenge is to now learning how to use a computer. And I never forget there was this one video that I've used in some lectures myself where it showed the provider on top of a computer leaning over a patient to put all the information in the computer.
Mm.
And that's how we had to update it. All right. But it was better than and more efficient than the paper chart. But it was a huge impact on the workflows and how it impacted the nurse, the doctor, the pharmacist. Some had to learn how to use computers. So, I mean, and that's only in the last 2 decades, Sarah.
Wow, that just is so mind-blowing to me hearing that that was kind of the early part of your career on typewriters and then thinking
Yeah,
that was innovative back then to
right.
transition to computers had to have been incredibly challenging, incredibly difficult to get the rest of the groups of, the nurses, the doctors, everyone on board to adopt this new technology now. Like, could you talk a little bit more about those challenges and how you were able to get everyone to kind of speak the same language and embrace the new technology?
Yeah, that's the biggest challenge, isn't it? And it's all about education and trust. You hear me use the word trust quite a bit because in healthcare and especially my pharmacy brethren are many times naysayers. We can't do it this way. And I'll never forget, I had a physician, actually a director of pharmacy, and one of my clients saying we were converting to CPOE with a pediatric population. And he said, you can use CPOE for peds and infants because we're going to kill somebody. And he slammed his hand on the desk. And I said,
Um,
we can create the right order sets that have even better guardrails than what we have today with a with alerts. You don't want too many alerts because of the alert fatigue, but gives you guidance on what the right practice is. The other thing that gave them comfort is you're still responsible as that clinician to make the right decision. So no matter what the computer tells you, you still have to use your tacit knowledge and your responsibility as a doctor, as a nurse, as a pharmacist, as a respiratory therapist to make the right decision for that patient, no matter what the computer tells you. All right. So
Right.
we spent a lot of time on education, and that helped to build that trust. And then once they got in the system and starting using it, it's not just sitting in a class and watching somebody else do it. You have to have the hands-on experience with it. And the comfort comes, and you start seeing some of the values. But now you start encountering other issues. It's like, okay, we have to do an upgrade of the system at midnight next Tuesday, and it's going to be down for 3 hours. So, yeah, but we still have to take care of patients for those 3 hours. So, what do we do? So, you end up doing these contingency plans where if
Mm,
it's down for this amount of time, you document it, and then you can put it back in the system. If it's going to be a prolonged period of time, you may have to convert to paper and then eventually put that information back in the electronic health record.
um,
The other thing it created, though, is kind of silos among organizations. So the information at hospital A was not accessible at hospital B.
mm,
And we had all this interoperability. So if Sarah, you got checked into um, hospital Z, and you were seen at hospital A before, I don't have visibility into any of that information that
yeah.
they used to treat you before. So that's the
Mm,
next phase that happened, is this whole interoperability to ensure that your information gets to the right provider, regardless of where the setting is. And we're not there yet. I'll be honest with you, which is alarming to me because I wrote a back of the envelope white paper on interoperability in 2006, and we're still not as efficient as we should be. If you're traveling to Arizona and get admitted to the hospital, they may not see your electronic health record
mm.
even
Wow.
today.
Wow. I mean, I can imagine that's incredibly beneficial, right? For the patient and the doctors knowing, what medications you're on. If you get in a car accident in Arizona, you can't you may not be able to communicate all of your past medical history, your medications and things like that. It's important
Exactly.
for those doctors to know that kind of information about you before they treat you.
Absolutely. And that's critical, right? And there's a lot of potential adverse drug events if we're just talking about pharmacy, and given they may not know you have a certain drug allergy, and
Mm,
they may not know all the medications that you're taking because maybe you're not conscious. So, and they may give you a med that you're allergic to, which could be devastating.
right.
Um, so that's some of the challenges we had, but some of the successes, I think, was spending the time side by side with the clinicians on the floor as we did these go lives, and helping them navigate the system. And it's key to have hands-on support up on the floors, next to the doctors, next to the nurses. And it was a huge investment of time and resources. Obviously, I mean, these implementations could cost hundreds of millions of dollars to convert to a new electronic health record. Fortunately, there was federal funding at that time for a lot of that, because the government was saying this is required for safety of patients.
Mm,
And then we've talked about this before, around HIPAA, and it's your personalized health information, and how critical it is to keep that as secure as possible. So
right.
then there were guardrails put up around that. And I should only see patient information if I have a need to look at it as a
Right.
provider. Um,
Yeah.
and there's penalties if you breach that. I mean, including prison, and pretty high fines have been administered up to this point for HIPAA breaches.
Mm,
So that I'm sorry I'm rambling here, but it's exciting to kind of look at where we've come from. And so now you have cybersecurity coming in.
mm,
And now all this, we were doing everything on servers initially, local servers at the hospitals. So you'd have a team maintaining that server. And then probably, I don't know, mid 2010, that time frame, we started going to the cloud. What's this cloud thing we're talking about? And it's
Mhm.
really remote servers is what it is, right?
Mhm. Right.
But it needs to be maintained. But that information's going through this digital highway. And how do we make sure that that's secure, that
Mhm.
others can't hack into it? So there's all these guardrails in healthcare, in banking. You came from the financial side.
Mhm.
It's critical all that is those highways are protected.
Right.
So there's a tremendous amount of work going there. Yeah.
Yeah, it's like almost a balance, right? Of that protection of your patient and their personal information, but like to your point of the interoperability and being able to share that information in pertinent ways that really benefits that patient and the doctors treating the patient. So it's that sort of balance of, and I think you nailed it with the trust, right? Having
Yeah.
that trust, for the whole ecosystem, right? That you're able to use that information in a way that's going to benefit patients and doctors, but do no harm to your patients.
Absolutely. And we've learned from that as we're getting into AI now. I call it, a colleague of mine called it augmented intelligence. And that's really the frame of mind that I'm using with it is this is going to help me do my job better. It's not going to take the place of my job, but it's going to make me much more efficient
Right.
with better data to take care of each individual patient. So we're going from treating the masses to starting to take care of Dave and to start to take us care of Sarah because we have more data on Dave and Sarah than we ever had before.
Right. And you mentioned before too with the sort of upgrade to these computers, right? If something happened during these backups and these upgrades, you still had to rely, the pharmacist still makes the decision, the doctor still
Right.
makes the decision at the end of the day. The computers are tools to assist the doctors in making the best decision, but they don't replace that doctor in that decision
That
making ability.
that's the key right there. And that's what everyone's afraid of, that my
Yeah.
job's going to be replaced. And I understand that fear. Um, I kind of look at it a little bit differently in that it's going to help me do my job better and safer. Um, and how do we ensure that? These algorithms that are being built with AI learning, the more data you have, the better those algorithms get with the information. But you still have to have a vetting process before implementing each of those stages. So just like we did with electronic health records, we would roll it out to certain areas first, certain. And as you got into more critical areas like pediatrics that as I mentioned earlier, or oncology where they're more complex, you get you have to do more testing and more vetting of the information it's providing in order to make sure that it's safe and you as a clinician trust it. Um, and it also gives you opportunity to see things that you haven't seen before. There may be patterns that, we don't have capability of catching all these patterns over time
Yeah.
that see little data points in a patient's care that's trending a certain direction.
Mhm.
AI can pick up on that and
Yeah.
we can intervene sooner than we ever could before.
Mm.
Many times we're reactive in our treatments and it really bothers me. We're treating versus preventing. And as we see data points trending in a certain way, we can act on that in an appropriate manner so we avoid it continuing to grow, So, we could see a spot on an MRI and we watch it.
Yeah.
And and now that we can trend all that now with the AI, and it's exciting. I mean, a simple use case for AI right now is medication reconciliation. And what I mean by that is, you may be on two or three different medications, but you may get them from three different pharmacies.
Mm.
So there was no way to really, without me sitting down with you when you got admitted to the hospital. So what medications are you on? Well, I take the blue pill and the pink pill and the white pill. AI now can pull data from all different sources, your prescription files, your what they call your claims files.
Mm.
And it'll give you a list of medications that you're currently on. And you may not be on all of those anymore because it may pull from old ones, but it gives you a checkpoint to say, yeah, you got this one refilled last month, so you must still be on it.
Mm.
And we couldn't get that information before without having the conversation with the patient. Now I've got that in front of me when I first meet with you, and we can validate it. And
Right.
it's coming in from all different sources. It's coming in from Arizona. It's coming in from North Carolina.
Hmm.
It's not just that one server in that one hospital or clinic that you were seen at before.
Yeah, it's incredible, right? And making sure we're not causing that harm to patients, right?
Right.
Making sure you're not mixing medications that you shouldn't be mixing with, right, to make you
Right.
sick, right? So I love that the notion of pulling all the information together to make that best informed decision about that patient and that
Yeah.
reconciliation of all of that data while also keeping those guardrails and those safeguards in place that we're protecting that patient's information and we're not sharing that in any like unethical manner or using any unethical data for our decisions that we're making about that patient.
Spot on, spot on. And you mentioned pharmacogenetics earlier, and I what that is basically looking at your individual DNA and how you metabolize different medications. And there's guardrails on that too. CPIC is a consortium of academics and clinicians who vet the evidence all the time and put different levels of, yes, we have enough evidence with this drug gene interaction that it could be an impactor on this individual patient. And that group is continually updating that evidence so that you do this pharmacogenetic test once in a lifetime. And
Mm.
then as new evidence comes out, you still have that same drug gene data on that patient that you
Mhm.
can update as new medications are administered. And that gets me excited because you're getting patients on the right medications that, you know, and it's happened with me. I was on a statin one time. I quit taking because my muscles ached. And I did my pharmacogenetic test, and I can't take that particular statin because it does cause side effects based on my drug gene interaction for
Mhm.
me, Dave. Now, Sarah could take the same drug and it doesn't have the same. Reason
Wow.
I'm relaying this is we can get that data incorporated into better personalized care now through the
Yeah.
use of AI. Right now, it's all these disparate systems, and you may have a report somewhere that says this, but I have no idea where that paper report is, you know?
Right,
So
right.
as we pull that data into the story of Sarah, the story of Dave, and the more data points we have in there, we have the better care plan.
Wow. Yeah, you're really getting
So
to that one-to-one like
I,
medication, that one-to-one care, right? How I'm different than you, how I process medication is different from you based on all those markers you were talking about with your DNA. Like that's such crucial information, I think that would be so beneficial for the patients and the pharmacists, like making sure you're prescribing the right medications to do no harm to your patient. So I
yeah,
love that notion of that
yeah.
personalized like one-to-one healthcare.
And I think that's where the electronic health record is going to evolve as well, because we built these order sets based on best evidence we have for treating different conditions or different diagnoses, right? And but we know now we have personal variability with in that as well. And now pulling this data in is going to make that information, that data, so much more robust
Mhm.
um, to really drill in. And we're doing it with gene therapy now. We're making tremendous strides in the treatment of cancers. And a lot of those drug discoveries are coming in through AI and leveraging all that data analysis to identify the new drug entities or uh, in order to ensure that the right patient gets the right drugs based on their genetic makeup as well. And that's what I'm excited, and that's kind of the next phase I'm hoping to be part of is okay, we took it from paper to computers, and now how do we layer in all this intelligence to even take better care of the patient, including identifying what condition are we treating and where should that patient be treated, because it may be and I can see a transition in health systems too, where the sickest are going to be in the medical centers.
Yeah.
If it's more acute care that can be done through an urgent care or a clinic, that's where the best and most efficient, cost-effective treatment plan for that patient would be. And all this is driven by this data, right? And we
Yeah.
can start track. And I read an article recently where we can identify based on the weather and if a patient's using public transportation to
Mhm.
ensure they get to the appointment on time, we may need to send them an alert that says, hey, you need to leave 15 minutes early because
Mhm.
the bus is running late.
Wow.
I mean, that's the kind
Yeah.
of
It's like
information.
real-time data on top of all that too, right? What's
uh,
happening today? What's happening in the news today? Is there a football game happening in your town? Is traffic
right.
going to be heavy that day? I love that notion of you're pulling in data from all sources really to provide that holistic, personalized care. It's incredible to think about all the possibilities.
I know it's exciting time. It really is. And it's a scary time for a lot of people.
Yeah.
And I think the stuff we're talking about and some of those guardrails, and there's an organization called Valid AI, and it's a consortium of um, health systems and academics who are basically just like we did with HIPAA and with CPIC, what governance do we need on how we handle this data? And that's going to build the trust, right?
Mhm.
As yes, we validated, and it's called Valid AI. And we validated this information, this data, and we validated the methodology and how it's implemented. So
Mhm.
that gives you the confidence that it's done safely.
Wow.
So we're learning from, the issues of the past, creating better systems to ensure it doesn't happen, and we're going to encounter new ones. So
Right.
it's constantly evolving.
Definitely, it seems like the wild, wild west sometimes in the world of AI. There's not a
Yeah.
lot of, that we don't have federal regulations yet, from the US government yet. Other countries are standing up their own regulations. Some states in the US are starting to put up their own regulations. But I think those regulations are definitely coming in the next, few years or so. And that it's just going
Yep.
to take time. I could see, building up what those regulations are, what makes sense per industry, per country, all of those different ways of making sure we're protecting that data that's fed into the models and the models themselves, right? Making sure the algorithms are not biased in any way as well. So I could see that in the next like few years or so taking off.
Well, that bias is a key point because a lot of the work, even early on in pharmacogenetics, was a bit biased. It was mostly European descent data that we had. And now we got to get into more diversity in treating different populations because it could impact your decisions
Yeah.
um, based on the genetics or the patterns in that certain demographic. And we need to take that into account.
Yeah.
Um, just because we treat, you know, a white Caucasian male a certain way doesn't mean that an Asian female is treated the exact same way.
Right.
Although our genes may still be the same once you get down to that personalized level. So
Yeah.
again, you can't broadly look at just a pop, oh, you're Asian, so we're going to treat you this way. We can't do that. We have to have um, the personalized data incorporated as well.
That
And we're
one-to-one
discovering that.
dedication. Yeah, I love that one-to-one, how you treat Dave, how you treat Sarah, how you treat
Yeah,
anyone is very specific and depending on all those markers in the data and building that, I think having that trust and transparency, right? And saying like, here are all your data points, here's how we use that information to make these decisions
that
and tracing it all the way back so you feel comfortable as a patient, sharing your data and being okay with that because you're seeing how it's being used and how you're benefiting from it in the long
right.
run.
Yeah, yeah. Big Brother's not just watching me, right? But that is going to and that's going to take a lot for the clinicians to be comfortable with as well. And it's like, it was a big step going into this from paper to electronics, and
Right.
now we're getting this word AI incorporated. We have this third head that's out here, telling me what to do, and well, where is that? third eye getting the information from,
Mhm. Right.
and is it valid? And that's some of the, I keep using the word vetting, but that's the vetting we have to do to
Yeah.
ensure that it's safely implemented.
Absolutely. And I love learning from the previous experience of moving from paper to computers and almost like in
Mm.
that iterative like education process as well, making sure everyone is educated and we're all moving towards that same goal and that we're doing this in the safest way possible to get to that ultimate
Absolutely.
goal. What do you think the timeline is looking like for all of these things? I mean, I could personally see the data and the regulations is going to be like the next few years, I can imagine. But how are you thinking about this timeline? And as you've seen before with that move from paper to computers, with the move from now computers to AI.
So we started CPOE probably in about 2006 to 8. And and even today there's still some healthcare practices using paper. But like by 2017, so it was 10 years, and it took that long to implement that to 2017, 18. So we're talking probably 10 years. I think what's going to be different this time is, and we're already seeing it, is we're going to implement little pieces of it, you know, little pieces of the AI. And it can be in scheduling, for example, and outreach to patients to remind them of their appointment. Now you get text alerts now, but
Yep.
it's going to go to the next stage. Okay, you're going to be having a colonoscopy schedule for next Tuesday, and you're going to get, instead of your paper instructions, yeah, that you pick up at your pre-screening appointment, that you end up losing that paper somewhere.
Yep.
You're going to get little alerts to say, okay, you have your appointment in 2 weeks or in 2 days. Here's what you need to do today.
Mm.
And then, so this is happening now. So you're going to see little pieces like that being implemented in a safe way, to ensure better patient care going into it. Even more importantly, as you get discharged from a service, that follow up that used to be all telephonic, right?
Mm-hmm.
Now we're, and you and I have talked about this, we'll find out, does a patient prefer to get an email, a phone call, or a text? And we can have it that personalized for that individual client or patient, that will communicate with them in that manner. And that technology exists today.
Mm-hmm.
Um, Now, as we get into, I'd love to get where we may not be on video here, but I'd love to get away from the keyboard at some point in the hospitals. So
Mm-hmm.
we're not stuck to our computers. We're using the voice recognition. We do that in some cases now. And and they're doing some testing with scribes right now, scribing instead of typing it all in. And again, that's part of that vetting process. So I think it's going to be an iterative implementation over time. How long is it going to take? It's going to take another 5 or 10 years before we see a major transition. I thought the electronic health record of today would look totally different by 2020. It still looks the same.
Oh.
And it's, and what's the impact? There's burnout with clinicians. And then we had an unfortunate pandemic that really burned a lot of clinicians out. And then you're burdened with this darn computer that's here too, and it goes down sometimes.
Mm-hmm.
Um, so I think that the more we can do to automate a lot of those route functions, scheduling, follow up. There's nice to have a personal phone call from time. I love to get a follow-up call from my doctor to see how I'm doing. That means a lot.
Mm-hmm.
This will allow more time for the doctor to do that
Yeah.
by
Yeah.
taking a lot of that data processing out of their workflow.
Right, they're not having to be glued to their keyboard necessarily all day to do those sorts of like mundane tasks, in a day-to-day
Yeah,
work schedule. They're able to spend more time with the patients and get that really do that. That's probably why they became doctors in the first place, to really,
exactly.
really be in front of your patients and really give them the best care, the most attention you possibly could, which is it's
Well,
amazing they're able to do that now.
exactly. But they have the tools to support it. I think of pharmacy too, and getting out from behind the counter in retail, or out of the basement in the hospital pharmacies. And and actually talking to patients. But we may have our computer with us, but that's our tool that really gets all that Sarah's information, Dave's information right
Yeah.
at her fingertips, which
Wow.
is going to be critical. It's going to be. I'm really excited about this next phase and intend to continue working down this path.
Yeah.
And I love how it's evolving.
Wow. I love hearing your stories about everything you've experienced now. And you really are such an innovator in your industry. You know, you've really embraced this culture of innovation and staying ahead of the new technology and not running from it, which I think is very, very incredible for someone in your field and having that expertise and being able to channel that down to the teams that you're working with, the people you're working with to kind of continue to foster that culture of innovation is it's so amazing to hear. And it's so exciting to hear you're excited about the new innovations with AI now and what we can do within this industry.
Absolutely. Thank you so much, Sarah.
Well, thank you. Well, we really enjoyed listening to you today. Can you tell our listeners, how to keep up with you and the things you're working on now, how our listeners
Yeah.
can get connected with you?
Yeah, you can always reach out to me on LinkedIn is probably the best way is Dave Wolfe on LinkedIn. My real name's David Wolfe, but it's Dave Wolfe on LinkedIn. You can email me at dave@fusionrx.com. That's my consulting firm. That's probably the two best ways to get in touch with me. I'm actually working on some fun stuff now, helping a client expand. They've got an incredible clinical team, and I'm just helping them expand into other areas that they can leverage their skill set beyond the kind of the microcosm they're working in now, and that's a lot of fun.
Yeah.
I'm still trying to figure out where I fit into this AI journey, so stay in touch because I think there's going to be a path there, and I'm still layering in pharmacogenetics. I think it's a little bit early on, but I think the timing's coming in that we're going to finally be leveraging that data. Payers are going to start paying for the testing.
Yeah.
Um, in the UK, they're doing it already. I think that we'll quickly follow that in the US. Well, I won't say quickly follow, but we're taking some strides. But it's all about personalized medicine, and that's still kind of my passion. I'm not I'm a pharmacist by background, but and not real deep clinically, but I still have a strong passion about how we can use that clinical data to get the right care of a patient.
Oh, no, that's your passion definitely speaks through, as you talk about all this. You're definitely very passionate about the work that you do and how this is going to make the biggest impact to the patients that you treat. Your passion definitely, fuels
Appreciate
from
it.
the screen, it radiates into into the screen for sure. So it's so incredible the things you're working on. The future is sounds very, very bright for you and your career and the next step. So I'm
Well,
very
you too,
excited.
Sarah. I mean,
Well,
I
thank you.
appreciate you bringing this diverse group into your discussions because it is touching all aspects of life right now, and there's many and there's a Venn diagram where there's a lot of crossovers, right? So um, let's leverage that in a safe way. Let's build trust and let's realize what the true augmented intelligence can provide for us.
Yeah, absolutely. The future is very bright, I think, especially in pharmacies and with AI in general. This is the second episode of many more discussions I hope to be having. So, yeah, very
Oh,
excited to hear from you, Dave. Thank you so much for being with us today and sharing your insights. This is an incredible conversation. I'm very excited for you and your future and your career, and we'll definitely stay connected and see how we can partner together, continue to expand on AI and pharmacies.
thank you so much, Sarah. It's an honor to be asked to be part of this. Thank you.
Well, thank you so much. Have a great rest of the day.
You too.
Thank you so much for listening. If you enjoyed this episode, please subscribe to this channel and tune in for more interviews with industry innovators. I'm your host, Sarah Cornett. Keep innovating.